So thank you, Dr. Alan Junkins, for joining us today and talking about how we can improve the reliability of blood cultures.
Okay, thank you, Ruth. Let's talk about blood cultures. Blood cultures is really extremely important. We consider in microlab really the most important culture type that we deal with. Obviously, sepsis is a incredibly important issue, but blood is not just like any other not just like any other specimen. What I got here is on the left side. This is a representation of a really well-collected sputum in a patient that has community-acquired pneumonia. So you can see lots of this bug that's causing the infection, but there's also some other guys in here, normal respiratory flora that come along with it. But if you look at blood, this is somebody who's got real sepsis. There's not a whole lot of bugs there. If the patient is alive, the concentration of bacteria is not really going to be very high. So if I treated blood like I treated sputum and just stuck a loop in it and streaked that out onto a plate, then what I get would look like this. Here's the sputum, which is great. I've got heavy growth of strep pneumo. And if you looked real close, there's a few little colonies in here of some other scant normal respiratory flora growing. But I know exactly what I've got there. So easy to interpret. But if I did that with blood, I really would not be able to get enough bugs in a loopful to be able to streak on that plate. I'd get no growth. So it's not really telling me anything. So the problem with blood, low concentration of organisms. Even in severe cases of sepsis, you're not going to have really high concentrations of bacteria. And blood is not hospitable. Bugs don't like it. Bacteria don't like it. It's got all this stuff in it, all these things that naturally come in blood, but also antibiotics. You know, if you've already started treatment, they're going to be on antibiotics. And even in other drugs that, you know, these pharmacists will give them to treat their diabetes or whatever. They're not exactly nice to hang around with. So bacteria aren't really going to like that. So what we do to overcome that is we're going to put it in a broth. We're going to put it in a liquid medium, which is going to dilute out all the bad stuff that's in the blood. And it's going to let them recover. It's kind of like going to the spa for a little while. They can kind of relax and they can get their health back and they can grow better. So we're going to let them grow in that broth. But the problem with a culture that we do in broth only like that is, one, the blood volume is critical. If you don't put in enough blood, you're going to have poor sensitivity. But if you put in too much blood, then you got too much of all this bad stuff over here from blood. And so that's going to lower your sensitivity as well. And there's also some issue with false positives, what I'm calling false positives, which I'll talk about a little bit later. But I think a big deal with blood, with broth cultures, is that I can't quantify. I don't know how many bacteria were in the specimen to begin with. If I put coagulative staph, if I grow coagulative staph from a blood culture bottle, I don't know if it started off at 5 cells in that bottle or whether it started off at 50,000 cells in that bottle. It's coming out the same, which is why you won't see a lab report coming from a blood culture that says we had scant growth of coagulative staph or heavy growth of coagulative staph. We can't quantify it. So that removes a very critical part of how we go about interpreting the significance of a culture. So these are the 3 main types of bottles that are available. These are the 3 manufacturers that make up probably 99% of the market out there. We use the Bactec bottles over here on the left side, but there's also Bacti-Alert and Versatrek bottles. They're all really fairly similar as far as the composition of the medium. They all contain sodium polyanethyl sulfonate, or SPS. That's the anticoagulant. And that has been chosen for blood cultures because it is the anticoagulant that is least toxic to bacteria. But I do say least toxic. It is still toxic to some organisms. So some bugs are not going to like it very well. A good example would be Gardnerella vaginalis, Peptostreptococcus. So these are bugs that actually might cause bacteremia and sepsis more often than we think, but they just don't grow very well in our blood culture bottles. So that's the best case scenario that we have for SPS, but it's still not fantastic. Some of them have these antimicrobial absorption resins that supposedly do absorb out antibiotics, and those do tend to work fairly well. So to go from a blood to a positive blood culture, this is what happens. This is specimen collection, and I'm just showing you the picture. I have to admit that I am not an expert in specimen collection whatsoever. I do not draw blood from patients. I've drawn blood from mice and from rabbits, but that's about it. So I will try to explain as well as possible. But what we get in the micro lab is going to be this bottle right here, hopefully 2 of these bottles. It has the broth in it and then the blood added to it. That comes to us. It gets put in these machines. These are our Bactec machines that we use in our laboratory. And like Ashley showed you a couple weeks ago in her presentation, here's the drawer that they're in. These bottles just slip right into these little slots. And they will incubate in there for usually up to 5 days. Usually at 5 days, we'll consider them final negative. I show the bottom of the bottle here because you probably never really paid any attention to this brown goo that's down here at the bottom, but that's really where all the magic happens. As a bug starts to grow, it's going to produce carbon dioxide. The carbon dioxide diffuses into this brown goo, and this stuff will start to fluoresce. So over here in this drawer, every 10 minutes, as they're incubating, it's going to shine an ultraviolet light on this brown goo. And if it sees fluorescence, it's going to flag it as positive. So that's how we'll know that it's positive. The Bactec machines that we use, so they're going to go into these machines. And just like Ashley showed you a couple of weeks ago, here's the drawer. This pulls out, the blood culture bottle just slips right into one of these little slots. And that's going to incubate it for typically 5 days is how long they'll go. Now, I'm showing you the bottom of the bottle here because you've probably never paid any attention to this brown goo that's at the bottom of this bottle. But that's where the magic happens. This is actually a pH indicator. So as a bug grows, produces carbon dioxide, the carbon dioxide diffuses down into that brown goo and drops the pH. But instead of changing colors, this one is going to start to fluoresce. So at the back of these little drawers in the window, it's going to shine an ultraviolet light. Every 10 minutes, it's going to shine an ultraviolet light on the bottom of that bottle. And when it starts seeing fluorescence, it's going to flag it and say, this one is positive. And then we'll do something with it. So I'll show you this picture again here just to show you. If you see this little green light right here, what that means is that there are bottles in that drawer that have been there for 5 days and they're still negative. And so when we see that green light, we can just pull those bottles off and throw them in the trash. Those are done. So 90 to 95% of all the blood cultures that we get in the laboratory, we don't do anything with. We put them on the machine, 5 days later, we throw them away. And that's it. We don't manipulate it at all. If it doesn't grow in the broth, it's a negative culture. But over here, you have one that's got a red light. And this is going to be sounding an alarm. And what we'll do with that is we will pull that off and do our stuff with it. We'll start with the gram stain, like Ashley talked about a couple of weeks ago. And that's a critical result. We will call immediately. Most places will probably call to the floor. We call to pharmacy, as Ashley talked about with the rapid bacteremia response program. So it gets called immediately. We'll do our micro thing. We'll streak it out onto some plates. It's a fairly simple workup. You know, if you look at all our protocols, we have all kinds of rules about how we work things up. Blood culture is really a fairly simple one. There's no normal flora of blood. And so we're never going to report out, you know, we got normal flora. Everything that grows gets identified. We don't necessarily do susceptibility testing on everything. In fact, we don't do susceptibility testing on everything. If we think that it's a contaminant, if it's a co-negative staph from a single set, we're just going to say minimal identification, call it co-negative staph, and we're not going to do susceptibility. We will say call micro. If a doctor decides they think it's important and they want susceptibility, then they can. But it's a fairly simple workup for us to do. And then, of course, there's the rapid methods. Ashley talked about the Verigene a couple of weeks ago, and there are some other ones as well that can be done these days. So let's talk about reliability of blood cultures. The first important thing is really who should get a blood culture in the first place. So we want to practice good diagnostic stewardship. That's going to be the buzzword for years now as far as the laboratory practice, good diagnostic stewardship. And I'm going to base just about everything I say, this whole presentation is going to be based on this document right here. We talked about CLSI when we mentioned susceptibility testing. They also produce guidelines for blood cultures. The new version was just published a couple months ago. So I kind of stealing some things from there. These are direct quotes from that document. Current practice guidelines do not include specific indications for obtaining blood cultures. And that's true. If you look around at all the different professional organizations, it's hard to find anything that says, these are the people who should get blood cultures. These are the people who should not. They also state that healthcare practitioners probably overestimate the likelihood of bloodstream infections in their patients. What they're saying is that there's a lot of people who get blood cultures where there's really a very low likelihood that there's going to be sepsis involved. So we're kind of over ordering. Now, I would counter that a little bit, and you might be like me because I'm looking at it and I'm thinking, you just saw that 90 to 95% of our blood cultures are no work for the microlab whatsoever. This is a potentially very serious situation. You know, if I were taking care of a patient, I wouldn't want to be in a situation where I'm going to miss it because I didn't even bother to look for it, right? So it would take a really low chance. If there's any chance whatsoever this patient has sepsis or bacteremia, then I'm going to feel like I need to go ahead and look for it. That's me. But these people also point out you got contamination issues sometimes. If you're doing the test, if you're doing blood cultures on patients have a very low risk of sepsis, but then you still have a decent contamination rate, then you have a situation where your positive predictive value is very poor. So you may have a situation like they mentioned right here, where of all the positive blood cultures, half of them are contaminants. So your positive predictive value, exactly how you go about interpreting a blood culture becomes a really difficult thing to do. So the general consensus, and I will say overall, nationwide, I think the general consensus is that we do order too many blood cultures. We order it on too many people. But the question there, the hard part is, who do you cut out? Who gets it? So this is what CLSI is indicating right now. This is what they came up with. I'm not going to read these through to you because you can look at it there and see it yourself. They did specifically kind of point out that fever alone is not very well correlated with bacteremia. And there are some things that you think of before, I look at, they're saying complicated pneumonia, which, we don't have to define here. We should define here what exactly complicated pneumonia is, but, in a typical community-acquired pneumonia, there's not really a need for a blood culture. That's kind of counter to what I've always thought. And there's a lot of subjectivity built into this. There's some clinical judgment that has to be done. Suspected sepsis, how suspected does it have to be before you say, okay, I'm going to order blood cultures? So this is a help, this is a step, but it's still a situation where you've got to leave that up to the clinical judgment of the ordering physician. So that's step one. I want to talk about specimen collection. And like I said, I don't collect blood cultures myself, but here are the two golden rules. These are the two things that we have to keep in mind throughout all of specimen collection. You must be constantly vigilant about proper skin preparation and bottle preparation to avoid contamination. You don't want the contaminants. So that's going to assure the highest possible specificity. That's going to assure that when you get a positive, you are most confident that this is true bacteremia and not a skin contaminant. The second golden rule, the number one most important factor in determining the sensitivity of a blood culture is the total volume of blood cultured. You must get high enough volume there. That's going to assure the highest possible sensitivity. So if you can keep both of these things going, if you can juggle both of these and keep them both in mind at the same time, then you can get high sensitivity, high specificity. But that's easier said than done. So let's go through specimen collection issues. Talk about here the adult version. We'll get to peds in a bit, but let's talk about adults. First of all, what should be collected? If a physician orders a blood culture, we want one set. A set is going to be one aerobic bottle, one anaerobic bottle, both of them collected from the same draw. That is a full blood culture. Should be collected from venipuncture. That's the preferred method. Only collect from a line if the clinician specifically requests it. Typically, you're going to have higher levels of contamination from lines. And do make sure that the site of collection is accurately recorded. You know, we had situations where a lot of our blood cultures were documented as having been collected from arterial sticks. And I had to question some of the nurses, are you really collecting all these blood cultures from arterial sticks? And they said, no, we're not. But that's the first thing alphabetically that comes up in Epic when you're ordering the culture. And so they just kind of click through it. So you do want to make sure. It's not going to make any difference to us as far as how we work up a culture. For us, a blood culture is a blood culture. But it can make a lot of difference as far as how it gets interpreted at the other end. So how many sets should be collected? Recommendation, 2 to 3 different sets. In order to diagnose sepsis, you want 2 to 3 separate sets. One set's not going to cut it. And the reason is you got to get adequate volume. Golden rule, you got to get adequate volume. You are not going to get adequate volume from one set. And second thing, that really, really helps us in interpretation of contamination. If I get coagulator staph from one set, I don't know what that means. Coagulator staph is by far the most common contaminant, but it's also one of the most significant pathogens in the bloodstream. So I don't know what it means when we get it from a single set. But if I get it from 2 sets or 3 sets, then I know it's real. So it's important to have 2 to 3 sets. In most places, the doc's going to have to order those as separate blood cultures. There are some places where a single order reflexes to 2 or 3 sets. Here's another one. Each set has got to be a different draw. If it's a venipuncture, line, whatever, each set is a different draw. Do not stick a needle in somebody's arm and draw 4 blood culture bottles, and call that 2 different sets. If it's a 1 venipuncture, then it's really 1 set. So it's got to be from a different draw. Going beyond 3 sets or 4 sets is really not very useful. Your sensitivity gets high enough after 3 or 4 sets to where you're pretty certain. If you haven't grown anything yet, you're not going to grow anything. So you really don't need to keep going beyond that. But physicians do use sequential blood cultures every now and then to monitor clearance. They want to see when the blood is sterilized, okay? However you define sterilized in that case. So can be used for monitoring, but really should not be used beyond 3 or 4 sets for diagnosis. When should they be collected? And I put these in here because I've gotten a lot of questions over the years from nurses who just are confused about why procedures are the way they are. And there's some things that I would say, let's simplify things here. The most important factor as far as when you should collect blood cultures is to draw before you start antimicrobial therapy. If that is all possible, do it before you start therapy. We want the bugs in the bottle without any antibiotics. Now, there have been all kinds of rules out there over decades about 15 to 30 minutes apart or an hour apart or whatever. Forget all that. That's completely unimportant, okay? If somebody has suspected sepsis, collect 2 sets right now and then start therapy. If that's ideal what you want to do. If you're going to add a 3rd set, then do it 6 hours later, 12 hours later, somewhere down the line within the next 24 hours. But the most important thing is before therapy, which means if you suspect, if you're going to start therapy in 20 minutes, then collect the 2 blood culture sets right now. Don't worry about any timing apart. The timing is not important. Aerobic or anaerobic bottle first, that's another question that I've gotten a lot of. And, I think it's too complicated the way we look at it. Here's the easy part, what I think. You want to keep air out of the anaerobic bottle. That's the main thing. So if you are using something like a butterfly, where you've got air in the tube, and that air is going to be drawn into the first bottle, then fill the aerobic bottle first. So that air goes into the aerobic bottle. But if you're going to be using something like a syringe, where you're going to stick the syringe in and the air is going to be up at the top of the syringe, so the air will go into the second bottle, then fill the anaerobic bottle first. Just as far as aerobic versus anaerobic, just think what I want to do is keep the air out of the anaerobic bottle as much as possible. But keep in mind, the aerobic bottle, in almost every clinical situation, the aerobic bottle is going to be the more important one. So if your total blood volume is low, if you can't get the total amount of blood that you need to fill 2 bottles, then make sure the aerobic bottle has the adequate volume. So if I'm using a syringe and I've only got 15 mils, then I'm going to say, I'm going to fill the anaerobic bottle, but I'm only going to put 5 mils in. And then I'm going to put the other 10 mil into the aerobic bottle. So I want the aerobic bottle to be filled as to the adequate volume, and then let the anaerobic bottle get whatever's left. Okay, speaking of which, how much blood per bottle? All right, like I said, here's the golden rule. Number 1 factor in determining sensitivity is total volume collected. Here's what CLSI says. For adults, the recommended volume for blood culture is 20 to 30 mils per culture set. You can't really do that if you're defining a set as 2 bottles. Here's what the manufacturers will say. The Bactec bottles that we use, 8 to 10 mils is what you should be putting in. BactiAlert is about the same, up to 10 mils. And the Versatrek doesn't have a pediatric bottle, so they have 1 bottle that can go from 0.1 to 10. But all of them, you're shooting for somewhere up close to 10 mils, okay? So I can get 20 mils per set, but I can't get 30 mils per set unless I add a second aerobic bottle, which I don't know of anybody who actually does that. So to kind of decipher that down, to cut it down to size, let's just say recommendation 2 to 3 sets with 8 to 10 mils per bottle, regardless of which manufacturer you're using. Now, we'd run into problems. We used to have problems here with people underfilling. Now I have problems here with people overfilling. So I would watch out. Don't overfill. You don't want to go beyond 10. Don't think that if 10 is good, the 12 is going to be better. It's not. If you put too much blood in, you're going to actually reduce the sensitivity. Remember that blood is not hospitable. The bugs don't like the blood. They like the broth a whole lot better. So if you have too much blood and not enough broth, they're not going to like it as much. They're going to grow slower, or they're not going to grow at all. And you will get what I call false positives. This is just an annoyance for the micro lab, because what happens if you have a lot of blood and you have a patient who has a high white count, then the white blood cell metabolism will cause the machine to flag positive. Now we'll take that off, we'll gram stain it, we won't see anything. We'll put the bottle back on the machine again, and it will flag positive again. We're still streaking out those plates. We're still looking at those cultures the next day, but nothing's ever going to grow. So too much blood just is an annoyance for your microlab, and try not to annoy your microlab too much. It's my public service message. Now, if your lab is accredited by the College of American Pathologists, and they are required to monitor blood volume in blood culture bottles from adult patients and to give feedback on that. Now, ideally, the way to do this would be able to do it at the time the blood culture bottle comes into the laboratory. And then we can put in the culture report. This is a blood culture on Mr. Jones. It is a low volume draw. So interpret results with caution, something like that, so that the physician knows that the sensitivity here may not be very good. If you really suspect sepsis and this comes back negative, you should draw again, get a higher volume draw. To do that, we used to visually monitor blood levels. We'd take the bottles when they come in, we look at it, we compare it to a bottle that we had added 5 mils of blood to, or 8 mils of blood to, and we would kind of compare them side by side. Pain in the neck, and it really, we couldn't do it here now when we are off campus and we have couriers that'll bring in, bags of 40, 50 blood culture bottles at one time. The staff's just not going to do it. Some places will weigh the bottles as they come in. And if it's too light, that means you didn't put in enough blood. The problem with both the visual and the weighing is that it's not very precise. They're not very precise at all. You're going to have to be really low before we'll be able to tell you that you're low. But now most of the machines will do automatic monitoring of blood culture volume, which allows us to produce reports such as this. This is a histogram that we can produce on our BACTEC machine, which can be done by unit or it can be done by phlebotomist, which shows you exactly how much blood volume was put into bottles from 0 mils up to greater than 13 mils. So I can look at it and say, we want this range right here. This right here, these 2 bars are the perfect volume. These are all overfilled. These are all underfilled. So I can provide that to units or individual phlebotomists. Same thing over here. They'll also make these box plots, which are kind of cool as well. The problem with these is that I do them monthly or quarterly. It can't go back on a patient report. So when Dr. Ramirez has a patient and they have a low blood volume draw, the report will make no mention of that whatsoever. So that's a bit of a problem with that. Now let's talk pediatrics. Oh my gosh, it's 12:26. Pediatrics. The blood culture bottle, there is a pediatric blood culture bottle. The only thing that is different with this is as a lower concentration of sodium polyanythol sulfonate, which means you should be able to add less blood because you'll have less toxic effects of the SPS. Not really particularly useful. There's nothing magic about these bottles and nothing that says they're going to work with 3 mils instead of having to have 10 mils. Nothing magical about them. I have never worked in a place that actually uses these. I think there are some pediatric only laboratories that use them, but we don't use them at all. Our pediatric patients put blood in regular adult bottles. When we do get pediatrics, it's usually just a single aerobic bottle. Anaerobic sepsis still appears to be very rare in pediatrics, so they don't send an anaerobic bottle unless there's a reason to suspect it. But I do want to point out that that doesn't get you off the hook as far as volume goes. There's been word on the street for decades about pediatric sepsis results in a higher concentration of bacteria in the blood than it does in adult sepsis. And therefore you need less blood. Well, as far as I can tell, that came from a paper that was published back in 1964 or something, and attempts to recreate that data have largely failed. Sometimes it's true, sometimes it's not true. So you can't depend upon that. So what happens is 1 bottle per order, just the air bottle. You're going to do fewer orders, less total blood. You're going to have lower sensitivity in pediatrics. It's going to be important, but you can't just put in 0.5 ml, 1 ml and think you're good. All right. So the gray area here, as far as how much blood you put in the bottle for pediatrics, it is very gray. There's all kinds of suggestions out there. This is what CLSI is coming up with now. The safe volume that you can draw for a blood culture is about 1% of the patient's total blood volume. And that really applies to children. It applies to adults as well. Here's your total volume. In case you didn't know, most of us were over than age 15, so we have about 70 mils per kilogram of blood. It's going to be a little bit less than that depending upon your BMI. So what that means is that in neonates, a 7-pound baby, the safe volume is about 2.5 mils. So don't go beyond that. Most of the time in pediatrics, we tell people we want 3 to 4 mils. But if you look at the 1% rule, that is safe down to a kid at about 12 pounds. So It's really nothing saying you can't go 5, 6, 7 mils in a pediatric patient. And then we just say in an adult-sized kid, just use the adult guidelines, 8 to 10 mils per bottle. But it's always tricky. I'll be honest with you, this 8 to 10 mils per bottle, if you put in that 1% rule, this would be safe down to a kid that's about 25 or 30 pounds. We are never going to get 8 to 10 mils of blood from a kid who's 25 or 30 pounds. Our pediatric nurses are just not going to draw that. So we struggle to get 3 to 5 pounds, 3 to 4 mils. Let me finish up here with the big issue we're all trying to reduce, and that is contamination in blood culture bottles. And why is that so important? A big reason is money, of course. There are dozens of studies that have looked at the cost of a contaminated blood culture. I've seen numbers, this here kind of summarized a lot of this paper that came out a couple of years ago, from $2,500 to $23,000 in extra hospital cost for a contaminated blood culture. You got to watch out for some of this. Different studies looked at different things. And some of these studies were done 40 years ago, and some of them were done 2 years ago. So, you know, the cost is going to differ there. But it's a lot of money. I look at a theoretical hospital system. We do here at Norton, we do about 5,000 blood cultures a month. So if you say it's a 2% contamination rate, and if you say it's middle of the range, $10,000 each, that means $1 million a month in extra hospital costs that are a result of just contaminations in blood cultures. So the numbers are up there and can be really pretty startling. But there's all these other issues that may occur as well. Increased length of stay, definitely. Unnecessary treatment, definitely. CLABSI rates, it depends. It will increase your CLABSI rates because some of these contaminants are not bugs that we normally consider to be contaminating organisms. Now, what do we do? How do we tell if it's a contaminant or not? And notice here that I've switched over. This is our policy, the way we do it. I think just about every facility is going to be a little bit different in how they tell whether something's a contaminant. So it's kind of hard sometimes to compare contamination rates at hospital A versus hospital B versus hospital C, because they may not be determining the contamination rate exactly the same. But this is the way we do it. First of all, these are your common skin flora organisms, okay? Common on the skin, but rarely cause sepsis. Coagulative staph, Corynebacterium, Micrococcus bacillus, and Cutibacterium. Those are the main ones. These guys down here are not so obvious. A lot of people consider viridans strep usually a contaminant. Aerococcus is a tricky one, often a contaminant. Viridans strep to me is a contaminant really right about 50% of the time. These guys all up here, Coagulative staph, Corynebacterium, Micrococcus bacillus, and Cutibacterium, are contaminants more than 90% of the time they are found in a blood culture. Viridans, not so much. Aerococcus, not so much. Now, for those of you who have moved on to MALDI as a means of identification, all of a sudden, we can identify all these other critters. These are bugs we never could identify before. In fact, if you had Chidococcus or Cucuria in a hospital that does not use MALDI for identification, you'd be calling it Micrococcus. All of these bugs here, Pinobacillus, Lyscinobacillus, Oceanobacillus, those are all bugs that we've gotten from blood cultures identified by MALDI, but if we didn't have MALDI, we'd be calling them bacillus. So basically, all of these get added to your list of bugs that are also common contaminants. There's a whole lot of bugs we can identify now that we couldn't identify before. So again, this is what we do. A common skin flora organism, one of these guys right here. We will look and see, here it is, this one with the asterisk, there's the contaminated culture. We look on any other sets that were drawn within 24 hours. So 24 hours on either side of the time of collection. Okay, here's another blood culture that was drawn, and it did not have that organism. So there's no other blood cultures drawn within that 48-hour period that can have the same organism. That, by definition, is a contaminant. Okay, by definition. That is a nice, objective way of doing it. It's not always correct. I kind of look at this similar to infection control definitions. Those of you who have to deal with infection control definitions all the time, you know, will say, this case meets the definition of a healthcare acquired infection. I know it's not. I know this patient had C. diff when they came in, but we didn't test it in time. So it meets the definition, even though it's not real. So there'll be situations here where there are some that we call a contaminant that really aren't. And there'll be situations where there are bugs that are skin contaminants that we don't call because of this situation. The problem then comes if there's no other sets that are drawn within 24 hours. Then it's a matter of judgment. Then I have to look up every single patient in this case, look up their signs and symptoms. Is there a catheter or some sort of source of infection that might explain it? How long did it take before it grew in the blood culture? Did it take 12 hours? Then it's real. If it took 36 hours, it's probably contaminant. And look and see what the doctor did with it. Did they actually treat for more than 48 hours? Because sometimes they'll treat for 48 hours and then drop it off because they decide it's a contaminant. Did they mention in their notes that this is a contaminant, or we're not going to treat it at all, or whatever? So that is going to be a subjective determination. So I sit there and do that for our system. I make those calls. It would be really interesting to have other people do it as well. If anybody in the Norton system wants to help me out with that, if you want to look at all our blood cultures and make your call, it would be cool to see how different people come to different decisions on that. But that's a little bit more subjective. But it lets us do things like this. We can put out monthly reports by unit with contamination rates. We can put out unit reports by the actual phlebotomist, what their contamination rates are. And we can follow contamination rates over time. Here's a couple of fake hospitals with their contamination rates changing. Okay, I am running late here, but I'm going to finish up anyway, so hang on here. What should it be? Less than 3%? That's what we've always kind of used. When CLSI put out their first document in 2007, they kind of pushed it down to 2% or lower. And in the 2022, they are really recommending that you should be able to hit less than 1% contamination. That's really hard to do. But there are things that can be done now to help out. How can you lower your contamination rate? First of all, good skin prep. I just threw this in here because this is word for word what the CLSI is recommending at this point. You need to look at whatever prep materials you use and follow the manufacturer's guidelines to the letter on those. That's going to be the main thing. I want to put in bottle disinfection. This is one thing that we found when we looked at contamination that a lot of people weren't doing. You need to disinfect the rubber septum at the top of the bottle. Even if you pop that cap off, you still disinfect the rubber septum. Alcohol, and let it dry. I have seen people who have put that alcohol on there and then they need to stick the needle in before it dries, because once it dries, the alcohol's gone. Well, no. You need to let it dry. As my old, I shouldn't say friend, I worked with him for like a few months at the University of Iowa, Frank Coots, a super star microbiologist. Bacteria die from drying, not drowning. You can't drown them in alcohol. But if you let the alcohol dry, they will die during the drying process, not during the wetting process. These things are also out there now. I don't know about you guys, but these companies have been really pushing to get in here in our place. They are diversion devices. The SteriPath, you start drawing the blood, and the first 1.5 to 2 mils of blood will be diverted off to the side. And so you're only collecting what's beyond that. This is the Curran device, which only has this little, can't really see it, a little tube that goes around in here where it's going to divert the first 0.15 mils and then let you divide by that. The reason for that is that the idea is most of the contamination, almost all the contamination, comes from the skin tag. That's going to be that first thing that you draw in from that needle. So if you can divert the bacteria from the skin tag someplace else, they won't go in the bottle. These will decrease contamination. I have no doubt that if you start using these, you'll have lower contamination rates. The problem is they are pricey. If you do the math on it, it probably will save you money in the long run, but you have to have the investment up front to bring these in. And from what I've heard from people who are using them, there are problems with phlebotomists not really liking them, not really using them properly. My concern also is that if you're using this one and diverting 1.5 to 2 mils, are we going to get enough blood volume to put in there? I don't like to throw away that 1.5 to 2 mils. Anyway, that's one thing that can be used. And then lastly, let me point out what I really think, because I've sat around and I've seen our contamination rates increase a lot during COVID. And I think it's because we're all distracted by other things. It's not an emphasis right now. So I would say you need to have administration to say, look, this is something we need to do. We need to lower our contamination rate. And then the emphasis gets put back on it and you can lower it down. It's hard to emphasize everything at the same time. I kind of understand that. And there's a lot of other crap going on, a lot of other things that are going on the floor. And then the nurses or phlebotomists who are drying this have a lot of other things to handle. But when the emphasis comes from on high, then we will be able to do things to lower the contamination rate. And I'm sorry for going long here, but that's what I've got. I'll be happy to take any questions if there's anybody still awake.
As always, this was very good.
Good. Alan, I've got a quick question. We'll read a lot about the, you talked about the CLSI guidelines and then Cumatech documents. What's the difference, or what's the use for both of those?
Well, they kind of, the CLSI, so it's Clinical and Laboratory Standards Institute, is an independent body. They take, people like, I would say like me, but people who know more about this than I do, who all get together and decide these things. So the CLSI document on blood cultures, for example, was co-written by probably something like, I don't know, 5 to 10 microbiologists and nurses and other people involved in clinical laboratory standards to come up with best scenario. It's kind of like a Cochrane review. They go through and they review all the publications and come up with guidelines for it. Cumatechs do kind of the same thing. Cumatechs are sponsored by the American Society for Microbiology. So there you're going to have microbiologists who get together and kind of write those up. They usually say sort of the same thing. The Cumatechs are only going to be involved with microbiology topics. CLSI will be on all laboratory topics. They kind of mirror each other quite a bit. CLSI has a little bit more oomph to them. CLSI is kind of what we know to deal with. But certainly with that, the Cumatech for blood cultures has not been updated in a long time. And I think there's not going to be as much emphasis from ASM right now in updating those.
If we don't have any, I have several questions. Ruth, do you have any question from the audience?
None. No. Where some people were asking about what is MALDI, so I included it in the chat just about what is MALDI-TOF. I don't know if you have any additional comments.
Well, MALDI is matrix assisted laser desorption ionization time of flight mass spectrometry, which is what we use now to identify most bacteria. It's a mass spec thing. It is a big step. It's an expensive piece of equipment. So yeah, you've got to be able to tell the hospital administration, this is something we really think is cool. We really need to get this. It is a much improved method for identifying bacteria and yeast, and has a huge database. So it allows us to identify a lot of bugs that we could never identify before. There's a lot of bugs that we just, like I said, blew off and called Corynebacterium species, and now we know more specifically. So it's an expensive instrument. The good thing about it is once you have it, it's cheaper to use than the biochemical testing that we use now, and we have used in the past.
I have a question regarding what you just mentioned. Is that the multi allow us to identify more bacteria? How much of allow us to identify more bacteria versus allow us to identify the name of the bacteria that in the past we should have a group and now we can pinpoint? Yeah,
I think a good example would be Corynebacterium, because we look at that and say, okay, we know what it looks like on the plate, we know what it looks like on the microscope, and we do a quickie little catalase test and it's like, oh, that's Corynebacterium, and that's when we were done. We didn't have any means to go any further than that, so we had to stop there. But now when we use MALDI, now we know we're getting various species of actinomyces. We're getting dermabacter, we're getting pseudoclavibacter. I had one in the blood culture this morning, the pseudarthrobacter. Okay, and so we can give a lot more specific names than we used to be able to give. These are all bugs that we were not able to identify in the past.
But at this moment, using multi, in the past we have, okay, this patient has corynebacteria. But
Yeah.
now using multi, do you have a blood that we didn't identify, we identify nothing and the multi give you the organism? Or is always something that in the past we used to identify, give it a general name, and now we can?
Well, the multi has to have a bug growing on a plate.
Okay, okay.
As of this point.
Essentially, we don't get new positive blood culture. We just
No,
get
no.
a better name or whatever is in the blood culture.
We're getting a more accurate identification.
Yes. Let me ask you a general question. I know that we don't know the answer, but let's say that because we discuss always the idea of getting blood culture for bacteremia or sepsis. If you have the patient with a regular infection, no, urinary tract infection, pneumonia, how often do you think that patients are going to get bacteremia with these infections that are not endocarditis, that would be probably, but how often do you think that a patient may get bacteria in the blood, and for how long do you think that the bacteria may be in the blood?
Wow, that's a hard one. I don't know. I think it's going to depend so much on the presentation, but also on the patient factors. Pneumonia, because when I was growing up, and we can talk about sputum cultures at some point. Sputum cultures have all kinds of problems. And urine has a whole lot of problems as far as culturing goes. So, I was always kind of told often the best lab test for pneumonia would be a blood culture. Because if you get it, you may not get it, but if you get it from a blood culture, then you know what you got. Okay. You might get strep pneumo from a blood culture when you don't get it from urine. Sometimes. It's not going to be every single time that way. So now they're kind of moving away from that as well. So I don't know. I would hesitate to come up with any kind of numbers or something because it's going to depend on so many different factors.
But you think that if a patient with pneumonia, since you mentioned pneumonia,
yeah,
pneumonia, ventilator, the patient is in the hospital with pneumonia. It's total, but it's going to be 5 minutes every 6 hours. It's going to be half an hour, 3 times a day. How often do you think that bacteria may go into the blood?
Oh, okay. So like a transient.
It's a tricky question because when you mention that the timing is not important,
right?
I try to say if every time that I get a blood culture, it's like going fishing. No, you have a big lake, and some people say you go to this area of the lake because this is where you get if I'm fishing for bacteria,
exactly.
I get one now and one in 2 hours and one in 2 hours, I'm fishing versus all the blood in the same time. Then I want to get your feeling.
Okay, I will make this up. Okay, I will try to make
it up. Yes, this is just you and me here.
Okay, I will try to make something up here.
And we're not taping this. This is.
I'm saying timing is not important when it comes to somebody who's actually got sepsis. Constant bugs in the bloodstream or constant release of bugs in the bloodstream. But in a situation where you have an infection or colonization and there's transient introduction of bugs into the bloodstream, typically, I don't think those last very long at all. Especially, again, it's going to depend on patient because all of us, I think, get transient bacteremia on an almost daily basis. You bite your cheek, you brush your teeth, you get a cut. There's going to be an introduction, and those bugs are gone quickly. They're taken care of. They're out of here. But you could have a situation where here's a project. Maybe you should work on this project. Blood cultures on totally healthy people. We're gonna do blood cultures. Dr. Ramirez, thanks for volunteering. We're gonna culture your blood every 2 hours for the next 3 days, and just see, can you pick up transient bacteremia? I think there is transient bacteremia, but I think it's very quickly. I think in a normal, healthy person with the low volumes that are going to get in, it's going to go very, very quickly. If you've got somebody with pneumonia, so they're sick to begin with, you're going to have higher volumes of bug getting into the bloodstream, supposedly, and it's probably not going to go away as quickly. Now, I can't give you like a half-life of strep pneumo in the blood. I think there's just too many factors that are come into play there.
And another quick question. You mentioned that one set of blood culture should never happen because one set you can never figure out this contamination or not. What do you think? You think that every hospital should have a policy that if someone order one set, automatically everybody should get two sets?
I like the idea. I tell you, we're pretty good here on the adult side. We almost always get two sets. So I think that our adult physicians here are good about that. Right before I left the University of Iowa, which was 13 years ago now, they put in a policy that said, when you order a blood culture, so a single blood culture order, then you are going to get two sets right now and a third set at a certain time period after that. So physicians only ordered one blood culture, but they got 3 sets out of it. I do not know how well that worked, how well it's working right now. You know, you can kind of see where some physicians may say, we don't want that. But still, that would be very helpful as far as getting your sensitivity and in ruling out contaminants. On the other hand, you could look at it and say, you know, you're going to have more contaminants because you're going to have 3 sets. You're going to have more likelihood that there's a contaminant in there, and therefore your total number of contaminants would increase. You just can't win.
I think you brought up the point that I think is relevant to a lot of the audience here, that we have not only the clinical perspective of blood culture results, but we've got the surveillance definitions that we meet. And we all know that with surveillance, you cast a wide net. So you're going to get some who clinically do not meet the definition for bloodstream infection or device associated bloodstream infection, but the responsibility on the surveillance side is to report those that meet the case definition, because as you were bringing up, it may not be a clinical definition, but it may be an indicator that you've got issues with blood culture processes or contaminants and so forth. So the information gathered from the surveillance side is not only, it isn't to be used for clinical evaluation of a patient. It is strictly for understanding the care practices that are going on in your facility and may help you identify those related risk factors. So pointing that out, I think, was very helpful, and clarifying that to some in our audience, just that
Right.
anything wrong if you say this meets the case definition and somebody steps back and says, well, but the patient clearly does not. Well, that may very well be true, but nevertheless, your patient may have met that case definition.
Right. Yeah. And you really, with the contamination thing, you know, contamination, we measure it really twice, because what I showed you with those reports and stuff is something that I do each month. So I go back this morning, I was going back and looking at all of June's blood cultures to figure out contamination rates. Well after the fact. That's going to be our surveillance. That's going to be the graphs and everything. But we also have to have our techs who decide on the spot, is this a contaminant or not? Because we're not going to do susceptibility if we think it's a contaminant. We're not going to report the full name out. I'm not going to tell you it's staph epi. I'm going to tell you it's coagulated staph. And put in that comment to saying call micro if you want further workup. So there's really 2 aspects there. There's the clinical side, which the lab techs have to do as they're working up a culture. And then there's the surveillance side, which I do monthly.
And as always, Alan, thank you very much. Excellent presentation. This is in response to some of the audience requesting more or a better understanding of microbiology that is critical for everything that we want to do in infectious diseases, antimicrobial stewardship, and infection control. And with this, thank you, Alan. Ruth, you want to close?
Sure, Alan, I was going to ask if you'd stay on the line with me just for 5 minutes at the end. And our topic next week will focus on a biostatistical topic. And then the week after, I asked Dr. Hudson Garrett if he would make a switch. And we were talking last night about the new CMS guidance impacting long-term care. So we will have then the session on August 3rd focused on long-term care and that new very important approach by the federal government. So next week, biostats, and Stephen will provide us some updates there. And we thank you all very much for joining us again. And this will be posted up on the YouTube website. Again, remember our 2 programs. I think Dave put in information. Our clinical research course will be July 29th. Be in person or Zoom, and then Infection Prevention Bootcamp 2022, where we'll have opening and closing and representation from CDC that will be part of this, and we'll be focusing on a lot of the basic practices that are important for infection prevention and control. That will be October 4, 5, and 6. So we will see you next week, and thank you very much.
Thank you.